So we've talked a bit about how we monitor the CML in the laboratory, but then the next question is, what does that mean to you as the patient and to measure your disease? What the BCR-ABL measurement tells us is the percentage, roughly, of cells that are there in your blood or your bone marrow that have the Philadelphia chromosome, have the BCR-ABL. And we measure this on what we call a logarithmic scale. So we kind of measure it by like times 10 or divide by 10, divide by 10, divide by 10. And each one of those steps where you go from 100% to 10% and then 10% to 1% is one log down or one step down on the logarithmic scale. And that just means that we can keep measuring quite low and it still means something. You can turn it into more meaningful numbers. So what we say is that when you get to 10%, that is called MR1 or molecular response 1. And then when you get down to 1%, we call that MR2 or molecular response 2. Now, back in the old days where we did lots of bone marrow biopsies in patients with CML, we would look for the amount of Philadelphia chromosome that was still there. And we always did that on 100 cells. Now, that's why if you're less than 1 in 100, so you're less than 1%, that was always called complete cytogenetic response. And nowadays, when we're just testing your molecular response in your blood, the equivalent of that on molecular testing of 1% is what used to be called complete cytogenetic response, and actually we still call that CCYR now. So the next level down, so a tenth less than that, is then what we call MR3 or major molecular response. Now, that is often a goal of treatment, and certainly below 0.1% or MMR is optimal response at any stage. But that's what that means. Major molecular response is less than 0.1%. And then we can measure that even lower than that. So once you go down to MR4, we now term that deep molecular response. So that's less than 0.01%. So anything less than that, deep molecular response. And often that's important when you're deciding whether you're eligible for treatment for your remission. And then even less than that, you can go to MR 4.5 and MR 5, which are even lower levels of BCR-ABL. And most tests can't get down below levels less than 0.001%. So that is less than 1 in 100,000 cells being positive for BCR-ABL. And the test just can't detect any less than that. So this is a little diagram that's in our British Society of Haematology guidelines about CML, and this just tells you what we're aiming for at different stages of treatment. As you can see, by 3 months, to get into the green or the really optimal response, we want to get to less than 10%, and then by 6 months, we like to get to less than 1%, and then we aim for less than 0.1%, so that's major molecular response at 12 months. Now, there is a sort of grey area where actually if you're doing okay, but not quite meeting those, we can often term that warning criteria. And again, with new updated guidelines coming on, there might be even newer nomenclature, newer ways to describe that. But that doesn't necessarily mean you need to do anything or change anything. It's just it's not quite optimal. So these are what we're aiming for treatment. But it's important to note that your BCR-ABL, which is determining how well you're responding to treatment, is just one aspect of what's going on. The other aspect is, of course, what side effects or what effects the medication is having on you. So we've talked about how we measure the BCR-ABL, what that means in terms of the scale, and then how that affects what you and your clinician together decide on what to do with your treatment.